obstruction on the other side. Now, we know that the anatomic defect, upper airway obstruction is the root cause. However, recent evidence demonstrate that it's just not an anatomic defect. There are other traits or pathophysiologic factors which play a role in its pathogenesis. Importantly, the percentage of contribution of these factors in each patient is different. That means OSA patient, OSA occurs in different people for different reasons. It's not always one reason. How efficacious will this be? Now, if we can measure these phenotypes easily, can we diagnose these patients better? Can these patients have a better response to treatment? So, where are we now? Now, we know that they are not easily available.
Pharynx from anatomical point of view. So that's the most important thing which is there. If a patient has a compromised upper airway, he or she keeps his passage open when they are awake. That means during wakefulness, there are adequate compensatory mechanisms to keep the passage open and these people can breathe comfortably. Of course, in very severe cases, you can hear some sound and they have difficulty in this thing. So during sleep, these compensatory mechanisms are compromised. That means there is a decrease in the neural output to the pharyngeal dilator muscles. And now this fall in neural output is two ways. One is that during sleep, it is sleep-linked decrease in the neural output. That's the one way of doing it. So there is hypotonia of the pharyngeal dilator muscle. There is a decrease in the compensatory mechanism, and it leads to upper airway closure. And also it will. When they are sleeping. That though you are saying that sleep apnea is happening in sleep, so actually the sleep period is intermittent, and during that period they have apneas and they don't breathe, and in between they wake up, and during that period they ventilate. So one way is that there is a sleep-linked decrease in the output. Second is that when there is a sleep apnea, so there is gas exchange problem, there is increase in PCO2, carbon dioxide, there is decrease in oxygen, and there is acidemia. So there is hypoxia, hypercapnia, and acidemia. So these are strong stimulants for breathing. So once the patient wakes up from the apnea, so these reflexes and becomes quite active. And many of these patients tend to respond to these changes of hypoxia, hypercapnia excessively. With the result, they overbreathe and land up into hypocapnia. And that hypocapnia, once it goes below, one is the sleep-linked neural output to the upper airway and diaphragm, which goes down and the upper airway closes. And second is when they breathe too much, they overbreathe, that is what we call loop gain. So loop gain is the response to a disturbance. Disturbance during apnea, hypopnea, that is hypoxia, hypercapnia. And when the response is excessive, normally the response should be according to the disturbance and the ratio should be 1:1. So normal ratio is 1. If the ratio is more than 1, we call loop gain, high gain. With the result, you tend to breathe more, hyperventilate, cause hypocapnia and apnea. So these are the two ways you stop breathing. So the second part is actually central apnea. The first part was obstructive apnea. So when we are talking about apnea during sleep, so there are multiple factors which are taking place. So the most important thing to understand here is that our breathing control is different when we are awake. It is different when we are sleeping. The moment we go to sleep, it goes up. The moment we are awake, it goes up. So depending upon number of arousals, and these arousals can be due to any reason. They can be respiratory or they can be would keep we have the what you call the different phenotypes or endotype. So anatomy we wake up. Sleep apnea. The upper airway is closed, so we try to breathe against a closed upper airway, as if somebody has throttled you. So you keep making it more and more and more, progressively increasing effort. When this effort reaches a particular level, you wake up. So other factors which can wake you up is hypoxia, hypercapnia, and dyspnea. So if your arousal threshold is very low, you will wake up very fast and terminate this apnea faster. So the impact of that apnea in terms of desaturation will be less. But you will be waking up faster, you will have more arousal. The number of apneas will increase, duration of apneas will become smaller. So you have more issues of arousals, less issues of hypoxia. So that is what you are trying. So when we treat these patients, actually different patients have different traits. So about, I would say 30% of the patients will have one or the other factors contributing to sleep apnea, and that is why they do not respond to CPAP alone. So you have to treat this. If the patient has loop gain, you may have to give them oxygen along with CPAP, or you may have to give them what you call this drugs? Acetazolam. That's what you may have to give them. Or if their PCO2 falls too much below apnea threshold, you may add a dead space. Or you can actually insufflate carbon dioxide. So there are different ways you can decrease the loop gain so that you prevent the development of central apneas. When they develop central apnea, they become CPAP intolerant. The other way is you can see arousal threshold is by looking into their apneas. If they have short apneas, then you know that their arousal threshold is low. The desaturation will be less. So AHI score will be very high. If a patient has long apneas, severe desaturation, that means their apnea threshold is quite high. Sorry, in the first situation it will be low. That means they wake up too fast. Their arousal threshold is too low. So that way, from the PSG, you get a fairly good idea. And loop gain, you know how you see loop gain in the PSG? Whenever there is an arousal at the termination of apnea, you will see their breathing, excessive excursion of their chest and abdominal, this thing. And then you will see it is followed by a central apnea. So these are things, and if they are there, because if you do the home sleep studies probably, you may miss all of them, you will not be able to see their link with the arousals and other things. So that's why I think 50% of the people are not able to tolerate CPAP, their compliance is poor. So we are trying to understand more and more reasons for poor compliance. If the compliance is poor, then we should look into the reason. And I think this phenotyping is an important factor, recognizing them, and additional treatment with CPAP. CPAP will remain the main treatment to keep the upper airway open. Along with that, you may give oxygen, you may give and you can add the dead space. You may have to, if the arousal threshold is too low, you may add some sedative drugs. Along with CPAP, you cannot give it alone, along with CPAP, so that you can, allow them to compensate. How is apnea terminated? It's another very interesting thing is that there are two ways apnea is terminated. One is during apnea phase, you have hypoxia, hypercapnia, acidemia, and respiratory stimulant will wake you up. Hypoxia, those. Second thing is that the effort. And this effort is genetically predetermined that at what effort you will wake up. So if you wake up too early due to genetically your arousal threshold is low, then hypoxia, hypercapnia becomes less important. So in the second case, if your arousal threshold is high, so ultimately hypoxia, hypercapnia, they build up. So with that, what happens? There is an increased neural output. And that sometimes can terminate sleep disorder breathing. And you start breathing normally. These are, I think, it's a bit complicated, but it's a very interesting pathophysiology. And in each patient, you can actually look into that. And accordingly, you can add that treatment with CPAP to improve their compliance.
Thank you, sir. Thank you very much. So, not a single factor is not responsible to control what's said. Multiple factors can play a role in the pathophysiology of obstructive sleep apnea. The most common thing is anatomic defect, and I think the airway wall stiffness plays a major role. Sometimes in a very obese patient also, they might not have significant sleep apnea if their airway wall is very stiff. So that is a very, very important factor. And particularly when a patient is not responding to CPAP, we need to look into a level 1 sleep study and see that are there any other factors contributing, like sir said, low arousal threshold or high loop gain or a pharyngeal muscle responsiveness. We might not be able to detect everything from the polysomnography, but with a level 1 study and looking at the raw data, we can take these clues and try to help our patients. Now, Dr. Dushyant, OSA in children is a completely different ballgame, and it tends to get even underdiagnosed than adults and affects the development of child in terms of growth, behavior, metabolism, and overall health. So, how should parents suspect sleep apnea in children? And is always surgery the final answer?
Definitely, OSA is more prevalent in children. Not more, it's there in children who have the most common cause of OSA in children is adenoid hypertrophy and tonsillar hypertrophy. But unfortunately, we will not be doing any tests for the children like polysomnography in Indian setting. So we will not be able to complete the polysomnography in children. They might not be able to tolerate all the monitors and all. But one thing we can do is we can just check we'll be just asking them what are the symptoms, like is the child snoring, is the child active during the day, or does the child have any sleepiness, or does the child is having any hyperactive behaviors due to the lack of sleep, or does he having any concentration problems or any memory problems. Basically, our treatment is based on history and clinical examination. If the child definitely have on examination a grade 3 or grade 4 adenoid with the tonsillar hypertrophy, that means most likely children will be having some component of OSA, obstructive sleep apnea. So, there is good evidence that adenotonsillectomy will definitely reverse the sleep apnea in children, but not maybe 90% of the time we will be successful in reversing the sleep apnea in children, but sometimes some underdiagnosed or some component might also be there which needs to be evaluated. Recently we have got one patient which I have done adenotomy, but still the child is having some difficulty in sleeping during the night, and parents are keep on coming to me like what can be done for the child. So I'm just thinking what should be done for the child. I just changed the management pattern like leukotriene receptor antagonists, intranasal corticosteroids after this one. So multiple things are yet to be diagnosed for children, especially with sleep apnea. For adults, you can do sleep test, sleep endoscopy, everything. But for children, they are little limited. We might not be totally treating them, totally diagnosing them properly and treating them. Adenotonsillectomy definitely holds a place for treating OSA in children. So they definitely improve post-surgery. Parents will be very happy that they themselves tell that child is sleeping properly. They doesn't have any snoring episodes and he is calm at sleep, and the parents will be happy like post-surgery.
Yeah, thank you. I think the most important points that you said is asking the history to the parents is very important, because sometimes children sleep in separate bedrooms and we don't know how they are sleeping. Asking the history of whether child is struggling to breathe and struggling to sleep in the night, fidgeting on the bed, excessive movements, and having any hyperactivity or unable to focus in the daytime. These are the two important factors we need to ask history, because in my practice in pulmonary, they come with a lot of pediatric patients come. So for them, everybody I ask, do they have snoring? Do they have mouth breathing? The first response from the parents is no. But when we probe and I want you to please go home and check and then get back to me, yes madam, they're snoring, they're keeping their mouth open and all these things. So first line surgery is definitely surgery, but I think as per recent evidence also, not all sleep apneas get abolished by surgery. We need to do a follow-up. Sleep studies are feasible in pediatric population, I think now, and we have to do a follow-up if the patients have residual symptoms, and there can be component of high BMI, or sometimes what happens is, I think timing of the surgery is also important. If the patients are like having these problems for a long time and there are some structural changes like high arched palate and all this happen, then after you correct also, they will continue to remain to have sleep apnea and they might require lifelong CPAP. So we need to look into all those. And what do you say, sir? See, if the surgery is done too late and there are structural remodeling, then they will be like always adenoid facies and chronic mouth breathers.
I would like to say a few things, very important aspects here. The peak of adenotonsillar enlargement in children is from 4 to 6 years. That's the time, the adenotonsillar enlargement occurs. And the most common cause of sleep apnea in children is adenotonsillar enlargement. One. Number two, the face growth. The growth of the face is very fast in childhood. 60% of the face is already developed at the age of 6 years. And 90% of faces, the development is complete by 11 years. These two things one must keep in mind. Now, third thing which is very important is the role of tongue in the development of face. Now, fourth thing, the next thing is the importance of nasal breathing. Now, if there is a enlargement of adenoids, the nose is blocked. Now, this child will be forced to breathe through mouth. Now, if you are breathing through nose, your mouth is closed, where is your tongue? Your tongue is in opposition with the hard palate. So it keeps pressing the hard palate and makes the maxilla wider. So tongue guides the growth of maxilla. So with that, your facial features become very good. The wide maxilla, wide mandible, big upper airway. Now, if the child develops adenoids at the age of 4 years or 3 years, now this child becomes a mouth breather. And face is growing and mouth is open. The tongue loses contact with the hard palate. So that constant pressure on the hard palate and the maxilla is gone. So they develop that long face syndrome, what you call narrow maxilla, high arch palate, and also because there is a what you call the between the upper and the lower jaw, the
overbite and
the overbite. So what is happening is that there is alteration in the growth of face, and this is the most important period. And if you, because your question was timing, because that's why I gave you this background. Now, if what happens? This child goes to pediatrician. They'll say no problem. Adenoids, with time it will regress. That's the usual answer. They go to ENT surgeon. Now, of course, because at 2 years, 3 years, previously people were not operating because of the complication. Now surgical techniques have improved. But still somehow that mindset for removing tonsil adenoid is more from recurrent infections rather than from sleep apnea point of view or face growth point of view. So any child who is snoring, any child who is a mouth breather, that means his adenoids are big. Even if he has nothing, his face is not going to grow in a normal way. He will develop long face syndrome and permanently small pharynx, and he becomes an adult sleep apneic when he will put on weight. So that's why removal of these adenoids and tonsil at the earliest is important. The larger you wait, 7 years, 8 years, 9 years, the more alteration in growth will take place. So the later you remove tonsil adenoids, there already the pharynx has become smaller, high arch palate, maxilla is narrow. So after adenotonsillectomy, there is residual disease. So still there is significant obstructive sleep apnea. The child continues to suffer. So in these children, you have to take the help of your dental colleagues. So what you do, maxillary expansion. So because your, what you call that mid-palatine suture is not yet ossified. It gets ossified after the adolescence. So you put in those, and that narrow maxilla now needs to be widened, for this thing. And then to maintain what you call this opposition between the upper and the lower teeth, you also have to see on how it is in the bite, how it is going to make difference on the bite for this thing. So the occlusive surfaces, which are inside will become outside, because when you will become this thing, but it has to be done very properly, maxillary expansion. The another thing, if the mandible growth is also affected, then osteosis of the mandible we have to do. Then even with this, if suppose there is a residual disease, then you may have to use CPAP. So children, if treated early, very early, then they develop this, say 4 years, 5. If you remove their adenoids and restore nasal breathing, then they become okay. So suppose you treat these children with surgery at the age of 9 years, and for 5 years they have been breathing through mouth, and they are just 4 years. Before that, then they have nasal breathing. So more number of years in their life they are breathing. So they become habitual mouth breathers. So then you need myofunctional therapy, MFT, myofunctional therapy to restore nasal. It becomes really a very complicated issue. So that's why when you set timing, I have to get into such a big background to explain what is the importance of timing.
Thank you. So Dr. Sharif, would you like to add to it what sir said, your experience with did you get any such patients where you had to do some dental procedures?
Exactly, ma'am. Ma'am, firstly, I would like to thank Suri sir, because he made my job very easy. And secondly, I would like to thank you as well for giving me this opportunity. Ma'am, usually, as sir said, in children, 24% of the children, the narrow arch maxilla possibility is there. The problems with the child would undergo with the narrow arch maxilla is, as I mean to say, is blockage of the airway passage leading to sleep apnea, obstructive sleep apnea, and the second is cross-bite relationship of the occlusal surfaces of the teeth. Ma'am, at the early levels, if the early intervention is done using a rapid maxillary appliance where we give a screw onto the mid-palatal region, where quarter ton of the screw will bring about 0.1 millimeters of expansion of the maxillary arch. Likewise, the child has to use this key, will be provided with a key, and if the child uses this appliance, the lateral movement of the maxilla would occur and the crossbite would be solved, and as well as the problem of the sleep apnea can be resolved. This is with respect to the maxillary arch. Let us think about the mandibular arch. Ma'am, in children, especially who are short of the mandibular arch, okay, relative retrogranthism, or in a specific condition called Pyrie-Robin syndrome, where you find bird faces, where the mandible is underdeveloped and maxilla is up to the mark, okay, in such individuals, usually the tongue size would be little bigger, and tongue could be, sleep apnea could be because of two reasons. One, the blockage can be from the retropalatal area, and the second, it can be obstructive. I'm speaking about obstructive sleep apnea. The second could be because from the base of the tongue, retroglossal area. When we use the advancing device to bring the mandible ahead to compensate the growth with that of the maxilla, so the tongue also elongates. We want the tongue to be not stiff and to be active and to be elongated. So when we have a narrow tongue, obstruction of the airway passage possibility is minimized. So that's how, from dental perspective, we could be able to solve the sleep apnea. And the second reason, as sir also said, it's a mouth breathing pattern. Sir, we have a specific appliance for this, where the advancing device can be we could place certain holes in the advancing device, such that the child could be eventually, periodically, as the child gets used to the nasal breathing, these holes could be closed, and this would help the child for breaking the habit of mouth breathing.
So this device is kept in the mouth?
Exactly, madam. This device is placed in the mouth.
In the night time?
In the night time. Minimum 8 hours it should be worn.
Are these
6 to 8
available
hours. Ma'am, there are two types of devices. One is a custom made and one is prefabricated. Okay. Ma'am, prefabricated, when I went into the article's studies point of view, the efficacy of the prefabricated things are not good enough. Almost, I can say, they carry no sense. Okay, so custom-made appliances are always beneficial to the patient. When you speak about sleep apnea with respect to sleep apnea appliances, I categorize these appliances into, with respect to the age, like children, adults, and elderly people. I categorize them with respect to the location where they are used, how they are used. And the other way is mechanism of action of the usage. Ma'am, with respect to the children, as I told you, we would be doing this. Ma'am, with respect to the adults, we have oral obstructive sleep apnea appliances. Of these, we categorize them into 3 categories. One is, the simplest appliance is a soft palatal lift appliance. Okay? Here, we make a retainer, okay, same like an Howlis retainer, with an extended structure into the soft palate that would lift the soft palate up and thereby increase the tone of the soft palate and provide sufficient space for the airway passage. However, there are certain drawbacks with this. This can help us out in solving the mild sleep apnea problems, but not to the major extent. Okay. Secondly, the gag reflex is the biggest discomfort factor that would make a patient not use this appliance. Then coming to the next version, mandibular advancing device. This is a top quality appliance for solving the obstructive sleep apnea problem. However, it is second to the CPAP mission. First is CPAP. In the people who are not able to accept CPAP for various reasons, the second order could be tried in the form of mandibular advancing appliance. Ma'am, although thanks to you, ma'am, we studied about all this and during our postgraduate time, and after that, when it came to our practice, we became more involved into the our specialty, and we neglected the sleep apnea. And ma'am, you made me, the moment you told me, I was very happy, excited to learn more about it. And I mean to say that's how I started my.
But I think the customization can be made, I believe.
Definitely it can be made. Definitely it can be made, ma'am. I'm coming into that part. Ma'am, now, the second, in 1903, Pyre Robin is a person who has invented the first advancing appliance called monoblock. After that, till 1982, no other device has been found out. In 1982, Cartwright and Samuelson came with a device called tongue retracting device. Tongue retracting device has got a mouthpiece with a protrusive bulb into which the tongue could be placed, and tongue will be retained in that bulb. Now, sleep apnea appliances can help us solve two problems. One is providing adequate space for the airway space. Second is it also helps in decreasing the snoring problems. Ma'am, based on, first what we would do is, we would be placing this appliance into the mouth, customizing this by taking the impressions, and we would register the bite, and then we would be fabricating the appliance. Based on the position of the tongue, okay, we put a soft liner inside the bulb region, and we would look for 3 weeks whether the snoring activity has come down or not. If the snoring activity has not come down, then we would give some more clearance and take the tongue a little forward. If, on the contrary, if the patient has any pain, then we can close that space, we can take the tongue back, and we can also close that space with the soft liner again. So, however, the major problem with this appliance is discomfort. Ma'am, it causes soreness of the tongue. Second, 41% of the patients, studies reveal that 41% of the patients do suffer with this problem. 39% of the patients, this is the study from Jacquin et al., what I'm saying you, which was been published in 2015, ma'am. 39% of the patients do suffer with pain in the tongue. And 6% do not like it because of aesthetic reasons. 8% complain of drooling of saliva, because when foreign body is being placed inside the mouth, drooling of the saliva would happen, and 8% complained of that. And 3% of the people had dry mouth. However, the rest were not using the appliance. Hence, when compared to a tongue retracting device, mandibular advancing appliance is quite very good, and significantly it reduces the AHI index. When we come to the mandibular advancing appliance, we record the impressions and we take the bite in the centric occlusion. We bring the teeth into edge-to-edge contact. This is called protrusion complete. When we need to understand what protrusion complete is, we need to see, in the main problem with the mandibular advancement is, there would be a premature occlusal contacts, which may lead to the problem, if not corrected periodically, which may lead to a problem of temporomandibular joint. So now when we come into the chamber, when we open the window of the temporomandibular joint and understand what is happening in the joint, ma'am, as we know that the mandible has a projection called condyle, and it articulates with the glenoid fossa. In between we have a disc, articular disc. So when the mouth is opened, or when the mouth is been protruded ahead, the condyle moves forward, downward, and medially. And when we look into the teeth point of view, the lower teeth glide along the palatal surfaces of the upper teeth and come into an edge-to-edge position. This is called protrusion complete. However, the child or the individual can move the jaw forward as well. So we take 65% of the maximum protrusion into the consideration, and based on that we fabricate an appliance. So this is how the mandibular advancement device would be made, ma'am. The main problem with the mandibular advancement device is periodic interventions, periodic check-up, follow-ups has to be done. And on time basis, properly the occlusal corrections have to be made. However, the problems what the tongue retracting device, tongue retaining device had, this more or less similar problems will be there with the mandibular advancing appliance as well.
Yeah,
Thank you
very much. I think, so recently I had a patient who came with, who said he's very happy with the mandibular advancement device that he's using, dental device. So this has been given to me by a dental specialist and I'm very happy. So then I said, okay, then let us check how happy you are. Let us do a sleep study with your level 1 study with the device inside. So because why did I say that? Because the upper one was separate, lower one was separate. There was no, nothing, only just, it was like a mouth guard, teeth guard. It was like a teeth guard. So I was not convinced. So we put that and we did the study and patient had AHA of 75. So it depends upon where you go, take a proper device. And I think most important thing is, as adjustment is required, to do our sleep study after putting the device and see not only snoring, whether all the events are abolished or not is very important.
Exactly.
So for surgery or for dental appliance, I think monitoring later on by doing a polysomnography is, I feel, very important. But thank you for taking up this. Now this is for Dr. Jyotirmayi. Now, as Dr. Suri has shown, about many patients of sleep apnea are also associated with comorbidities and psychological problems, commonly depression and anxiety, or a combination of both. Some of them, they don't even try CPAP. The moment we put within 5 minutes, they'll pull out the CPAP, and they're very highly anxious people. How do you approach these patients? In fact, any of my insomnia patients, if there is a comorbidity of anxiety or depression, I send to her. And I tell them that both need to be addressed separately just by treating in pharmacological ways. Do you suggest?
Yes, ma'am. So just like Sir had pointed out in his presentation about the comorbidities in obstructive sleep apnea, in obstructive sleep apnea, we do see a lot of psychiatric illnesses like depression, anxiety. There was this study which was done in Kashmir, which I came across, so which measured the prevalence of psychiatric or mental illnesses in obstructive sleep apnea, and they found that about 50% had some kind of a psychiatric illness. So that indicates that it is important to recognize the comorbidities here as well. Why? Because first of all, it can be a barrier for diagnosis as such. Because with anxieties and depression, sometimes they wouldn't want to come to the doctor, and here the OSA is not diagnosed. Or they wouldn't want to be treated, under treatment, because they would have their own fears with the anxiety issues and all that. So because of these two barriers, it's important to recognize and it's important to address these issues. So how to go about it? Let us say this person, like you were telling, that he was afraid of this CPAP machine. So first of all, before coming to a conclusion that it is his fear that is causing or he's claustrophobic, we have to also see other reasons, like how a human being adapts to different, every human being has a different kind of a reaction to a sick role. Some people, they actually like being sick also, a lot of attention being given by the family members and all. But some people, they would, even though if they are very sick, they would want to deny that fact. So sometimes it could be a dislike of using the device because they wouldn't want to be in that role, like a patient, daily wearing that. So is it that that person dislikes that machine? Or are there other factors like, let us say sometimes sometimes bullying can happen at home also, that I have seen few times, like wherein people were taking medications or using some machines. So either their children or the relatives, why do you need this? Why do you have to keep this? So sometimes they wouldn't want to, and they would tell the doctor, no, I don't want this. And many a times it is the fear of keeping a mask in an enclosed, space. So they can have a panic attack. So they can feel that they're suffocating and they would not want to use that. So there are non-medical ways where we can encourage the patient after recognition, which we call a systematic desensitization. So here what we do is we for any kind of a fear, we kind of expose the patient from the least fear causing to the most fear causing. So the least fear causing could be, for example, we ask the person to just hold the mask and just get acquainted with the mask, what it is, what are the different parts of the mask, how it is connected. So a few days, let him just, be with the mask, than completely, not opening it, keeping in a sealed cover and, fearing that something might happen and all. So after a few days, if we ask them to just, when he's awake, not directly, if he has a problem with keeping it in the night time and if he has had a panic attack, then we tell him that when he's awake, he can just keep the mask to the face for 10 seconds or starting with 5 seconds, so that the fear slowly, he gets used to it. It's the least fear causing, he can do it, so that because he knows he can remove the mask after 10 seconds. So after that, slowly, based on how he responds, we ask them to keep the headgear and everything also, like with the machine, when he's awake, while doing his daily activities, like while watching TV, when he's in a kind of a relaxed mode while watching TV or doing some other course, when he's awake, he can keep it for few minutes so that he gets acquainted. Then finally we ask them while on the bed, to try in the night time for shorter durations, not for longer time. And let us say if we also focus on the thought process of the person, because these patients who have these anxiety and panic symptoms mostly have a thought error, which is called as catastrophizing. So they catastrophize an event. Let us say they have this mask, they keep on imagining and thinking, I'll not get my oxygen supply and I might die. Death is something that they might fear finally. So we will have to address those automatic thoughts that they are getting, which are erroneous thoughts, by showing them proof and showing them videos and explaining them the mechanism, how it works, because they might be ignorant of it. So then finally, after exposing them to shorter durations, we can ask them that in between, if they have anxiety issues, they can remove the mask and do some breathing exercise and again keep it back. So that way we can help them for proper treatment adherence.
Thank you. Very nicely put. So this is a big issue. Many of them do not want to use it for various reasons. One of them could be stigmatization, thinking that the first thing whenever we prescribe a CPAP, patient says is, can I skip it when I want to travel? Because I don't want to use it when I go for a wedding in front of my relatives. I don't want to use the machine in the night. Many patients tell that. So now, as she said, first thing is to make them understand the significance or impact of not using. And also sometimes children can act both ways. Sometimes they help in motivating the father. Daddy, you have to keep your CPAP mask, otherwise I also won't be able to sleep. Like that, children sometimes can become motivating factors also. So once we address all those reasons, I think what she said, first putting the mask on, letting the patient only put the mask without straps and without the machine, not connected to the machine, actually gives them the confidence to try it for some more time. So one thing I would like to say here is sleep medicine is not for money making. So it gives us a lot of satisfaction when our patients improve. It takes a lot of patience and time and understanding. So, but it's a very, very common problem, like our COPD, asthma, it can become our bread and butter. But we have to have patience, particularly when they don't respond, we have to spend more time. Okay, so Dr. Dushyant, this is for you. Now there is always a divide between pulmonologists and ENT specialists when it comes to management of sleep apnea. Patients independently go to ENT specialists for snoring and sleep apnea. They go to pulmonologists. Pulmonologists advise CPAP. ENT specialists advise surgery. Okay. So, though ideally it should be a multidisciplinary approach, like how we approach a case in a tumor board, multiple specialties sitting across and deciding what is best for the patient. So, there is a first-line surgery wherein to facilitate CPAP, we do certain ENT surgeries. Then there is a curative surgery wherein we do more extensive surgeries. Now, how do you choose your patients? What type of surgeries do you prefer? What factors predict a good response? Recently, yesterday, there was a patient, a VIP patient, who met many sleep specialists across the country. So he was advised surgery, extensive surgery, lateral pharyngoplasty and epiglottis, some other epiglottis surgery and all these things. So some ENT specialist is advising that some other sleep specialist said, no, don't go for surgery. So he was thoroughly confused. So when do you suggest surgery? And what are the good predicting factors? When do you say no for surgery? And lastly, one word about what is the future for hypoglossal nerve stimulation in our country? Are they being done anywhere, or will it be picked up later on?
So, first of all, snoring and sleep apnea is definitely a multidisciplinary approach, ma'am. It is good to have multiple specialists involved in this treatment of a single patient. So, we have many factors, like from today morning onwards, we are listening to many things. Not only one consultant can answer all the things. So, it needs pulmonologist, ENT, dental surgeon, psychiatrist, everyone. So, for me, I am more in favor of, as the patient, we'll just see clinically, we'll see the stop bank questionnaire, BMI, everything, anatomy, how is his anatomy, how is his mouth opening, how is the thyromental distance, everything we'll see, how is his nose, is there any sinusitis or any other nasal problem is he having, how is he oriented towards the diagnosis and treatment, is he really willing to take the treatment, or is he just came to get some surgery done to get away with the problem? Ideally, it is not the case, because yesterday I had one patient, he was coming and telling me, "Sir, do some surgery so that I'll be fine for 2 to 3 years." So for those patients, I'll definitely not do any surgery because they'll anyhow come back to us after some procedure or something. So for me, to select a patient for any surgery is first to give a compliance for CPAP. Suppose if he is having any nasal problem or anything, we just do some small basic septal correction or anything to make him adhere to the CPAP treatment. And the second one is any palatal surgeries we'll be doing any palatal surgeries for patients we are having mild to moderate OSA only, and that too Malampati grade 2. That's all. Grade 3, grade 4, it is not advisable to any surgery, so that the result won't be that good. All the surgeons usually they'll be doing, but the post-operative PSG, I don't think many of them will be doing and following up with the patient and all.
So one thing I would like to ask you here, do you do DICE before, if you are doing the salvage or curative surgery, in the DICE, what type of collapse is more amenable for surgery?
Lateral and circumferential, it will be easily to dilate during any palatal surgery, ma'am. Other than anteroposterior tongue-based collapse, it is very difficult to treat. I am not that favor of surgeries for OSM. Only minimal surgeries are good. Actually, we have to orient patient and make them understand the diagnosis. We have to show them the DICE. We have to show them that this is what is happening. So, and it's an evolving branch. Maybe if we get trained in some difficult surgeries, and if we have a first-hand experience, then we can advise some patient. That too, very choosy. We should be very choosy to a particular patient in advising any surgery and all. And hypoglossal nerve stimulation, right now, nobody is doing in our country. And some of the centers in the West, they might be doing. And that looks little bit more attractive and feasible, so that it will be taking some input from the respiratory muscles whenever the patient is breathing. At the same time, it will give an impulse to the hypoglossal nerve, the tongue will come forward. So that might solve some problem with the tongue-based obstructive sleep apneas and all. And it's an implantable device, and patient may not be wearing any device like CPAP and all. In certain patients, I don't have any personal experience with that one. Might be in future if we get a permission in our country. For selected patients, it can be done. Okay. It looks little bit more attractive right now.
Simpler.
Yeah.
Okay. Thank you very much. So the patient that I told you about yesterday, when we went into the whole history, he was not able to tolerate. He was on auto CPAP with the nasal mask, and he could not tolerate a nasal mask. So he went everywhere. He was prescribed a face mask and using face mask. But the problem is, the moment he puts a nasal mask, or he was mouth opening or freezing congestion, that is because of he has a DNS with big inferior turbinates and sinusitis and tonsils. So if this patient undergoes ENT surgery, then maybe he'll be better off just with a CPAP with a nasal mask. So that was what I could figure out yesterday from that patient. Rather than doing the simpler thing, he was doing like this, wherein using a face mask for an unaddressed nasal and tonsillar problem.
One more thing, metabolic surgery also plays a role in treatment of OSA.
Exactly.
We can't tell any obese patient that by doing any ENT surgery, he'll be off any CPAP or snoring. That is unrealistic. We just have to tell him that, see, this is the problem. This could be, you have to reduce your weight. You have to maintain your lifestyle. Then only some amount of AHI can be reduced. With CPAP, you can just reduce some more. You'll be bit more comfortable. You just have to try to educate them rather than advising straight away surgery to any patient.
In fact, our bariatric surgeon, Dr. Maidar, could not be here. Actually, he was supposed to cover this angle. When nothing else works, your BMI is 45, 50, and obesity hypoventilation syndrome is there. Whatever machines you use, you cannot cure completely, and bariatric surgery comes in a big way there. But again, for any modality of treatment, we have to do a follow-up polysomnography. So with this, I would like to have some concluding remarks from Suri sir. In the present scenario, what type of, simply, how do we go forward with whatever available phenotyping and correct practice of medicine? How do we better our OSA patients?
First of all, if we are looking into different modalities, like you just mentioned, orodental devices, surgery and CPAP, then the first thing which you do is you conduct a sleep study. On the basis of that, you quantitate the severity. If the patient has severe disease, that means the AHI score is more than 30, then the first line treatment is CPAP. So there is no doubt about it. And you can add other treatment as adjunctive treatment. So in the adjunctive treatment, you can use either surgery or dental device. If patient pressure requirement is very high and patient is uncomfortable and it is interfering in the compliance, then you do nasal surgeries if they have enlarged turbinates, if there is a polyp or significant DNS is there. So this is an adjunctive nasal surgery which will decrease significantly the pressure requirement and may also improve quality of life in these patients. So that's one. Second thing is, again, if there is no correctable nasal problem, but the patient has large tongue and basically pressure requirement again is very high. So in that case, you can use a hybrid treatment. You give CPAP and you give a dental device. Now, after all, what we are doing, when you give CPAP, you create a kind of a positive pressure in the pharynx that pushes the tongue forward. So you're disease. Mild to moderate, always CPAP. So first line remains CPAP for moderate and severe. If there is an issue of compliance, add nasal and adjunctive surgery. If that doesn't work, then you can consider surgery. Now, surgery, you should understand that surgery never cures. It at best reduces the severity. So surgery may reduce the AHI score by 50% maximum. In fact, most of the surgeries, the criteria for success is AHI reduction of 50%. So that's why if the AHI is 40, you reduce to 20, still it is moderate disease. If somebody's AHI score is 30, you reduce to, 60, you reduce to 30. So even after surgery, the disease is severe. So you will consider surgery where the AHI score is 15, 20. So it is reduced to less than 10. So you achieve fairly good, you have either normalized or you have reduced the disease to mild and make it less toxic on the long-term basis in terms of consequences, cardiovascular consequences and those things. So you can always consider surgery as this thing. But the problem with surgery is that pharynx is a structure which has three components: nasopharynx, oropharynx and hypopharynx. To find out where exactly is the obstruction, and but we know that in majority of patients, 70 to 80% of patients, obstruction is at multiple levels. So that means you require multiple surgeries. So if you do only uvulo-palatopharyngoplasty, you are only addressing nasopharynx. Nasopharynx, isolated nasopharynx obstruction is only in 30% of patients. 70 to 80% of sleep apnea patients will have naso as well as oropharynx obstruction. So that means not only you have to address nasopharynx through uvulo-palatopharyngoplasty and its variant, lateral pharyngoplasty or this or that, you also have to address the tongue base. Because oropharynx, what is the interior structure? Tongue. So either you pull the tongue forward or you reduce the tongue size, tongue reduction surgeries, or you do what you call pulling the tongue and through its attachment to the genome. So there you put in some kind of device and pull it forward. So most common is the tongue reduction, base of the tongue, reduction surgeries you do to address the oropharynx. So now whenever you are doing surgery, you are actually doing combination, the nasopharyngeal part as well as the oropharyngeal. And then ever since we have started doing DISE, drug-induced sleep endoscopy, now we are realizing more and more the role of epiglottis. Now 17 to 20% of the patients have epiglottis collapse or related to that, So that means you may also have to address the epiglottis or laryngomalacia, those problems. So surgery is at best reducing the problem, not curing the problem. But then you have to be a little more pragmatic, practical. Suppose you give CPAP to a person whose AHI is 40. Now this person does not use CPAP every day, or he removes CPAP after 5 hours. So and he sleeps for 8 hours and uses CPAP for 4 hours. So that means for 4 hours, no disease, corrected. But 4 hours, there is a problem. So with this kind of treatment with CPAP, although it is very efficacious, the overall reduction is 50%. Because the time when he is not using CPAP, he has disease, and that disease will result into consequences. So here surgery and then CPAP with this kind of compliance are becoming equivalent. So what you can do is, you can do surgery, reduce the severity from say 60 to 30, and now you give CPAP, you further reduce from 30 to 15. So what is actually happening is your assessment of the situation, your assessment of the patient's behavior. Over a period of time, you should understand what is the compliance, what does patient want, what does the patient want. whether patient is interested in surgery, whether patient wants to use, because most of the patient would not like to use a device on lifelong basis. They want one-time issue, but one-time issue cannot be helpful in majority. So you may do surgery and give him dental device, or you may do surgery and give CPAP. But when you do surgery, you have to be very careful that you don't cut the pharynx too much, because soft palate, when you when you increase the pressure in the pharynx, it should touch the tongue, and that's how it will seal pharynx from oral cavity. If you cut too much of pharynx, then the air will leak from the pharynx to oral cavity and start coming. So there is a CPAP failure. So many patients who undergo surgery, if the soft palate has been cut too much, and when you give and surgery has not done well, then you give CPAP, then there is a CPAP failure also, because there is a leakage. Because when you give CPAP, the pharynx should be closed and sealed from oral cavity or formulate. You have these three. The best is you treat with one. Where treating with one is not possible, use adjunctive surgery, nasal surgery. And if that issues cannot be addressed, then you use combination therapies. So CPAP and give, you can give, take surgery and give dental device. There is another situation, very interesting situation is when a person is obese. So many people advise bariatric surgery and think that with bariatric surgery there will be a significant weight loss, about 25 to 30 kg, and that should cure obstructive sleep apnea. Again, it is trivializing or too much simplifying the pathophysiology of sleep apnea. But what we have noticed after bariatric surgery, when there is a loss of 25-30 kg weight, majority of people are not cured of sleep apnea. It's only a small percentage, 15-20% will be cured of sleep apnea. But one very interesting thing happens to these patients, that majority of them become position dependent. So bariatric surgery followed by positional therapy. That's another option. A significant percentage of the patient, if you do bariatric surgery, their sleep apnea will become positional, and you give them positional therapy and they are cured, so you can avoid CPAP in them and do that. So I think this is the way, as ma'am has rightly said, it's a multidisciplinary approach, and when we decide, we should take into account patient's wishes also. What does the patient want? And then there can be options, and you can use those options. But the bottom line is CPAP is the treatment of choice for severe disease. For mild disease, option between CPAP and dental device, mild to moderate. You can also use surgery, but the problem with surgery is good evaluation, because what it happens during night, during sleep, dynamic obstruction of the pharynx, you cannot assess this during wakefulness. Whether you do endoscopy, whether you do CT scan, or you do dynamic MRI, you won't be able to, during a wakefulness state, you won't be able to, whether it is lateral cephalometry, know exactly. So you have to evaluate this patient during sleep, which is very difficult technically, putting an endoscope when the patient is sleeping. And to have this, to create that sleep, you are using drug. So again, drug-induced sleep and the natural sleep, there can be a difference. So there is always an error of evaluation of the site of obstruction. So when you decide that I want to do this kind of surgery on the basis of preoperative evaluation, even including dyes. With dyes, things have improved, but previously we could never know exactly what are the sites of obstruction. So any surgery when you do, the result would be between 35 to 85% with the same kind of evaluation. So much of variation. So that means it's compromised. Now we are getting into a next level. What is this next level? Is what you call we use what you call this modeling. Three-dimensional modeling.
Yeah.
You use the MRIs and this thing. You create the model of upper airway. And on the basis of that, you also calculate the critical closing pressure. It is the pressure at which the upper airway closes. And then you perform virtual surgeries on them. So you do tongue reduction, or you do uvuloparatopharyngoplasty, or you do this, and then see what happens. So by doing the virtual surgeries, by doing 3D modeling, then this thing is happening, and when on these virtual surgeries, there is a significant reduction in the critical closing pressure. That means which is a sign of success of upper airway surgery. People are moving in that direction. Again, this is a new area. How much it is going to help? Ultimately, we will know that pre-surgery and post-surgery PSG will tell us in terms of improvement of these patients. So that's where we are. We are definitely moving forward in this area. And once our surgical techniques become more simpler, lesser invasive, maybe addressing the multiple areas, our evaluation of likely sites of obstruction becomes much more clearer, and that we can actually do by three-dimensional modeling and by doing virtual surgeries on them and creating that kind of picture and test it then on the patient and see that it is actually helping us in improvement of this patient. Probably surgery will become a very important, because ultimately I think all sleep apnea patients would like to have something one time. They would like to have it is efficacious as long as it is used, but it is not effective because compliance issues are there. You don't use it for whole night, you don't use it daily, so it becomes less effective. Surgery is less efficacious, but 100% effective, because you have to use it one time. There is no compliance issue here. So once the surgery becomes efficacious, if it has the same efficacy as CPAP, then probably it may be the best treatment, as we have the techniques, are coming, robotic surgeries are coming, less invasive, ways of reducing the tongue size or lateral pharyngeal wall. So these are, I think, are there, and let's hope in the next 10 years things will, I think, definitely change. Till that time, I think CPAP is the gold standard treatment.
Thank you, sir. Very beautifully put. Before I close, I think I forgot to thank ResMed company, who are also partial sponsors for today's event. Thank you, ResMed. And thank you all the panelists for explaining various aspects of sleep apnea beautifully. So, any of you would like to see the hooking? We are there available. Students, we are there available. We'll just give farewell to Dr. Suri, and our team will be here to explain.
people don't want to spend so much money.
But for the patient,
It has ESB also. You should have get ESB also included in this.
see this other one here.
Bone safety, robotics.
We have a request for a second night study also.
Put it on speaker
This we are going to
We're
change.
going to change it. We're going to
Only
change
for
it.
because
today.
the electrical interference.
In fact, they have a better product that
We
we're
want
going
to
to get.
keep like a foam bed.
Yes, that's what it's home
That wooden.
And you'll see within a week's time this whole place.
I'm already impressed.
Get the wooden.
Now I have
No
targets on me.
artifacts. To
Yes.
reduce artifacts.
But I'm very keen on all this designing things. This morning I sent it to for design. I think I get up to this. That's what we are doing.
Wooden.
పెట్టండి తర్వాత తీసుకుంటాం.
So you can get small therapy options. Proper nostrils. And then frame okay. Fine. Okay.
ఇంకా కొంచెం
This is actually a medium size. Small size. So the smaller size will be better.
లీక్ అవుతుంది. What's one side?
చేంజ్ ఏమైనా
Yeah.
కింద సెమీ సర్కిల్ లాగా రావాలి.
No, it's not.
This is the positions where our oronasal will be forming the layer, semicircle layer వచ్చేసి దాని బ్రిడ్జ్ అవుతుంటుంది. ప్రెషర్ కంట్రోల్
ఆ పోర్స్ ఏవైతే ఉన్నాయో ఆ నాస్ట్రిల్స్ మీదకి రావాలి.
ప్రెషర్ పడకుండా చేస్తుంటారు సార్.
ఇక్కడ లీక్ అవుతుంది.
కొంచెం ఇది పైన ఇది ఒక్కటి సెట్ చేస్తే సెట్ అవుతుంది సార్. ఇప్పుడు సెట్ అవుతుంది. మ్యామ్ ఇట్లా మీన్స్ లైక్ యూ కెన్ ట్యాప్ కొంచెం ప్రెజర్ పెట్టండి.
ఇది మనం స్టార్ట్ చేద్దాం.
మీరు ఎక్సైట్ లేని పొజిషన్ ప్రెస్ అయినట్టు ఫ్లో విల్ బి నాట్ అఫెక్టెడ్. ఫ్లో విల్ బి
polysomnography test. So to perform electrodes, EOG electrodes, electroaculogram, EMG, chin EMG and leg EMG, and ground electrode, and airflow sensors as nasal and thermistor sensors, and respiratory efforts bells, chest and abdominal bells, and snore sensors, body position sensor, and pulse oximetry. So these are the electrodes and sensors we'll use to perform the sleep study test. So next we'll see how to apply these electrodes on body. First, applying EEG electrodes, we'll use International 1020 measuring system to apply the EEG electrodes, which uses the nasayan and anion preocular points as the landmarks. So nasayan is on the nasal bridge, anion as the backside of the head. So all the electrodes will be placing 10 or 20% from the landmarks. So we are using only frontal, central, occipital electrodes to perform the sleep study test, and M1, M2, which is on the masted bone, backside of the ear. So for example, all even number electrodes will be applying on right side, odd number electrodes will be applying on left side. So the M1, M2 electrodes are the reference electrodes. M1 electrode will be acting as a reference electrode to the EEG channels. If, for example, M1 electrodes will not working properly, if you are not attached M1 electrode properly, we will not get EEG signals. So it should be applied properly. For example, the nasayan to anion length is 40 centimeters. The CZ, you can see the CZ point there, that will be exactly in the middle of the head. So that will be 20 centimeters from the nasayan, also in ion. So, and we can see the C3 application. For example, the M1, A1 to A2 length is 38 centimeters. The C3 will be the 30% from the A1. So that will be the 11.4 centimeters. From other side also, C4 will be the 30% from the M2. That will be the 11.4 centimeters from the M2. So you can see the central view and side view of the EEG electrode application. All the even number electrodes will be on right side, and the odd number electrodes placement will be on the left side, and the M2 is the moisture on the masted bone, and it is on right side, M1 is on left side. So next, EOG electrode placement. So two electrodes are using to record the eye movements. One is E1 and another one is E2. E1 is applying 1 centimeter below to the outer canthus. E2 is applied 1 centimeter above to the outer canthus. So it will record all horizontal and vertical movements of eye. So eye movements will help us to identify the REM sleep. And M2 electrode will act as a reference electrode to the eye channels. If, for example, M2 channel is not working, we won't get eye signals. So it should be applied properly. And next is the chin channel placement. Three electrodes should be placed to record the chin muscle activity, and one electrode on the middle of the mandible, 1 centimeter above to the mandible, and two electrodes will be placing 2 centimeter below to the mandible. So one is right sided from middle of the mandible, and another one is left side from the middle of the mandible. Total 3 electrodes. And chin muscle movement also help us to identify the REM sleep. During REM sleep, muscle activity will decrease. And next is the ground electrode. Ground electrode will be placing exactly on the forehead of the central of the forehead. So we should avoid deep wrinkles while applying this electrode. And next is for airflow and respiratory bells attachment. So in the respiratory bells, chest and abdominal bells are using to measure the respiratory efforts. So one belt is tying on chest, another belt is tying on abdomen. So these two electrodes will represent the respiratory efforts. And airflow sensors. So two sensors will be placing on nose, to monitor intake or outflow of the airflow. So two prongs will be placing on nose, third prong will be in front of the mouth. So that is the nasal and thermal placement. And the snore sensor. So PGO sensors are used to indicate the degree and duration of the snoring. That is the lateral interior neck to the superior to the larynx part. So that is a snore sensor placement. And next one is the pulse oximetry. One external oximeter will be attaching on patient finger to monitor the arterial oxygen saturation. So few factors will be affecting these results. If patient is wearing nail polish, or if we are not connecting in a proper position, we will not get the good signals. And the leg EMG placement. So two electrodes will be placing on each leg and on the interior tibialis muscle, and it should be 2 to 3 centimeters apart from each channel. So that is the leg EMG placement. And these leg channels will help us to identify any leg movements, and if patient has any restless leg syndrome, these channels will help us to identify. And the ECG electrode placement. 4 ECG electrodes will be placing on patient body, and one is on right arm, left arm, and lower limb electrode, lower left limb electrode, lower right limb electrode. 4 electrodes will be placing on patient body to record the cardiac rhythms. And after applying all these electrodes, and we should perform the inspection of equipment. So we have to make sure all wires and all head box connect to the electricity, all patient details enter into the system. We have to perform examination thoroughly before starting the test. So this is the, so as per 1020 system, we are marking the site, and after that we have to clean through with new prep gel, and after that, after cleaning the area, we are attaching the electrode with the 1020 paste. So that is all for the electrode placement.